Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid and our today's topic of discussion is vasculitis, a very important topic for the preparation of USMLE Step 1 and Step 2 exams. I've seen a lot of questions from vasculitis in UWorld. We will be starting with large vessel vasculitis first, and then moving onwards, we will also discuss medium vessel vasculitis and small vessel vasculitis. I will see how many of the sub types of large vessel and medium vessel vasculitis I can discuss in this lecture. So we'll start with the large vessel vasculitis first, and I'm using first aid for USMLE Step 1 preparation. This first aid book is uh, very high yield, is very high yield for step 1 and step 2 preparation. I would recommend using first aid with your UWorld, because if you use first aid with UWorld side by side, in that way you can do active studying, not just the passive studying of reading UWorld. Okay, if you guys have any questions, you can ask me in the comment sections. I would love to answer your questions, or if you want me to teach any specific topic from first aid, let me know. Okay, let's start with the giant cell arteritis, also called temporal arteritis. So this large vessel vasculitis, which is called giant cell arteritis, is also called temporal arteritis. It has two names, so you should remember both names. Okay, um, usually, temporal arteritis is seen in female over the age of 50s. That means it is usually seen in the older population, more common in females than in males. Okay, and this disease is, why is it called large vessel vasculitis? Because it is most commonly involving or affecting the branches of carotid artery, which is a large vessel. Okay, um, what would be the patient's presentation with giant cell or temporal arteritis? Usually, an older, above the age of 50 years old female presented to your clinic with the unilateral headache or possible temporal artery tenderness or jaw claudication. These are the usual findings in patients of temporal arteritis. It can lead to irreversible blindness due to occlusion of ophthalmic artery. So, this is very important finding in temporal arteritis. Irreversible blindness could be the complication of patients of temporal arteritis due to occlusion of ophthalmic artery. So, it is very important to diagnose it as soon as possible and treat it before doing biopsy of temporal artery. Okay, it is associated with polymyalgia rheumatica. What is polymyalgia rheumatica? Polymyalgia rheumatica is also seen in females above the age of 50. That's why it is associated with temporal arteritis. Okay, so what is polymyalgia rheumatica? In the polymyalgia rheumatica, patient usually present with pain and stiffness in the proximal muscles, for example shoulders, for example neck muscles, or torso or hip muscles. Okay, so pain and stiffness in proximal muscles. Okay, along with fever, malaise, weight loss, all constitutional findings. Okay, it does not cause muscle weakness. Okay, polymyalgia rheumatica present with the pain and stiffness in the proximal muscles, but not muscle weakness. This is important point to remember. Okay, usually we treat polymyalgia rheumatica with low dose glucocorticoids. Okay, um, moving forward on temporal arteritis, when we do the biopsy of temporal arteritis, we will see focal granulomatous inflammation. Okay, and along with that, inflammatory markers will be increased, for example increased ESR, increased CRP, and IL-6. IL-6 is very important interleukin associated with temporal arteritis. It correlates the disease activity. Okay, so try to remember interleukin 6, try to remember the biopsy histological finding of giant cell or temporal arteritis, which is focal granulomatous inflammation. Basically we will see granulomas under the microscope. Okay, try to remember association of temporal arteritis with polymyalgia rheumatica. These are important points you should remember for your exam point of view. Okay, how what are the treatment options for temporal arteritis? The first line treatment option is high dose glucocorticoids, and we give high dose glucocorticoids prior to temporal artery biopsy to prevent blindness. Again, very important. Once we see patient, we find out their symptoms, we will treat patient right away with high dose glucocorticoids before confirmation. Before we do biopsy, before we confirm the patient has temporal arteritis with biopsy, it is very important to treat them first with high dose glucocorticoids to prevent blindness. Okay, if the patient only has polymyalgia rheumatica, we will treat them with low dose glucocorticoids. Okay, if the patient has giant cell arteritis which is associated with polymyalgia rheumatica, we will treat them with high dose glucocorticoids. So basically the treatment of choice for both polymyalgia rheumatica and giant cell arteritis is same, which is glucocorticoids, but the dose is different. Okay, in polymyalgia rheumatica we give patient low dose glucocorticoids, while in giant cell or temporal arteritis we will give them high dose glucocorticoids. Now look at the image A, which is, I don't know where is the image A here. This is focal granulomatous inflammation. You will see a lot of granulomas. Okay, this is the histological finding seen in giant cell or temporal arteritis. Now let's move towards a second large vessel vasculitis, which is Takayasu arteritis. Okay, which is also a large vessel vasculitis, usually seen in Asian females, usually seen in younger females. Okay, so let's talk about the differentiating points between giant cell and Takayasu arteritis. Okay, so in that way, when you see a question, you can easily differentiate if the question is leading you towards giant cell or the Takayasu. Okay, so giant cell is usually seen in females, and Takayasu is also seen in females, more common in females than in males. Giant cell is usually in the older population above the age of 50, while the Takayasu arteritis is usually seen in younger females. This is the one differentiating point. Okay, giant cell or temporal arteritis usually affects the branches of carotid artery, while Takayasu arteritis usually involves aortic arch and the proximal great vessels. Okay. Third differentiating point we can see is the patient's presentation. Obviously, patient in giant cell arteritis usually present with a unilateral headache, claudication, or temporal artery tenderness. While patients with the Takayasu arthritis usually present with the upper extremity weakness, constitutional symptoms will be there. For example, fever, fatigue, weight loss, night sweats, along with arthralgias, myalgias, skin nodules. These would be the findings in Takayasu arthritis. Okay, the histological finding in both giant cell and the temporal arthritis is same, which is granulomatous, granulomatous thickening. Okay, and the treatment options are again same. We will treat both of these conditions with the glucocorticoids. Okay, but for temporal arthritis you should remember that we give high dose glucocorticoids prior to temporal artery biopsy to prevent blindness. Okay, irreversible blindness due to anterior ischemic optic neuropathy is very important complication related to giant cell or temporal arthritis. Okay, now, moving onwards, we will talk about medium vessel vasculitis. Okay, the first medium vessel vasculitis is Buerger disease, or Buerger, whatever it is, or also called thromboangiitis obliterans. Try to remember both names; they are very important. Usually, the thromboangiitis obliterans is usually seen in younger males, more common in males than in females. Large vessel vasculitis were more common in females rather than males. So this medium vessel vasculitis, Buerger disease, is more common in males than in females, and it is associated with tobacco use. Okay, smoking. Usually in the case scenarios, they will give you smoking history. Males with the smoking history. Males with the smoking history. Okay, Patient usually present with the intermittent claudication may lead to gangrene or to amputation of two digits. Superficial nodular phlebitis. These are the findings which usually see in patients with Buerger disease or thromboangiitis obliterans. This is so the B image is for aortic arch and the great vessels. Okay, this is B is Takayasu. A is focal granulomatous thickening, which is seen in giant cell arteritis. B is aortic arch, um, and the branches. This is usually what Takayasu arteritis. Third, this is look the gangrene and amputation of digits. Very important finding in thromboangiitis obliterans. Okay, you should also remember the histological findings we see in thromboangiitis obliterans. Try to memorize these stuff because they ask you questions. These types of questions are very common in your world. So the histological finding in thromboangiitis obliterans is segmental thrombosing vasculitis with vein and nerve involvement. Okay, segmental thrombosing vasculitis with vein and nerve involvement. The first line treatment is smoking cessation. Okay, for thromboangiitis obliterans, because smoking is the leading cause or risk factor for thromboangiitis obliterans. Now, very important topic from the medium vessel vasculitis, which is Kawasaki disease. Kawasaki disease is also called mucocutaneous lymph node syndrome. Every disease, like giant cell arteritis, also called temporal arteritis. Takayasu arteritis does not have any other name, but Buerger disease, also called thromboangiitis obliterans. You should remember both of these names for every disease because you never know which. I have seen a lot of questions where they would say they would give you all the findings of Kawasaki disease, but in the options they'll be like, what is it? Is it mucocutaneous lymph node syndrome? Okay, now you memorize everything with Kawasaki in your mind, and you did not pay attention to mucocutaneous lymph node syndrome, which is the another name for Kawasaki disease. So there are chances you are going to pick up the wrong option. So here it is very important to memorize both the names. You never know what name or what name they would give in the options. Okay, so Kawasaki disease is also called mucocutaneous lymph node syndrome, usually seen in Asian children. This is the disease of children. Okay, usually below the age of 4. Okay, okay. So Kawasaki disease usually the disease of children below the age of 4. Now, easy way to remember Kawasaki disease is you should remember crash, which is very important mnemonic for Kawasaki disease. Okay, so crash stands for conjunctivitis, which is non-exudative bulbar conjunctivitis. Okay, R stands for rash. What kind of a rash? Erythematous rash on the extremities that spreads centripetally to the trunk. Okay, so C stands for bilateral non-exudative conjunctivitis. R stands for rash, which is erythematous desquamating rash, usually first seen on the extremities and then it moves centripetally to involve trunk. Um, Third is A stands for adenopathy, usually cervical lymph nodes are involved more than and their size would be more than 1.5 centimeter. So C for the bilateral non-exudative conjunctivitis, R for desquamating rash, A for adenopathy, usually cervical lymphadenopathy. S stands for strawberry tongue. Okay, and so these are the findings related to mucositis. Um, and H stand for hand, foot, and mouth disease. Okay, hand and foot involvement. H stands for hand and foot involvement. There would be swelling and erythema and edema of the hands and feet. Okay, so These are the findings which we usually seen in patients with Kawasaki disease: bilateral non-exudative bulbar conjunctivitis, rash, polymorphous desquamating rash, adenopathy usually cervical, strawberry tongue, oral mucositis, hand foot changes like edema, erythema. Edema means swelling, and erythema means redness of the hand and feet, and then fever. Now, how you diagnose Kawasaki disease? It is not important to have all the findings to diagnose Kawasaki disease. So you should remember that if a patient has fever for 5 or more days, to diagnose Kawasaki disease, you should have fever for 5 or more days. Okay, fever for 5 or more days plus 4 of the crash findings, not all the crash findings, any 4 of the crash findings with fever for 5 or more days. If fever for 5 or more days with any of the 4 crash findings are present, we will diagnose it as Kawasaki disease. Okay, but fever for 5 or more days is very important with any of the 4 crash findings, then you will diagnose it with Kawasaki disease. Okay. um, Complication, one very important complication related to Kawasaki disease is coronary artery aneurysm. That can lead to thrombosis and rupture of coronary artery aneurysm and can cause death. So is a very um, important complication you should remember related to Kawasaki disease, which is coronary artery aneurysm. How do we treat patient with the Kawasaki disease? We usually treat with them with IVIG, that means IV immunoglobulin, and aspirin. Okay, the treatment option for um, giant cell or temporal arteritis is high dose glucocorticoids. The treatment option for polymyalgia rheumatica is low dose glucocorticoids. The treatment option for Takayasu arteritis is again glucocorticoids. The treatment option for thromboangiitis obliterans, also called Buerger or Buerger disease, is smoking cessation. The treatment option for Kawasaki disease is IVIG and aspirin. Treatment is very important, along with you should remember their symptoms. Okay, so I think, yeah, this is all you should know for these topics. And in the next lecture, we will talk about other vasculitis syndromes. Okay, till then, bye bye.